Okay, conscious of time, we're already 2 minutes in, so we'll keep people coming in as they're joining with us, but we'll crack straight on. So, hello everybody. Let me just get my correct presentation screen up. So, first of all, today then, a quick shout out. So, we were meant to be joined today by Sunita. So, Sunita is a good friend and a colleague of mine who is also doing the fellowship programme. So, she was going to come today to talk to you about a project that she's running as part of her fellowship. Unfortunately, she can't be with us today. So, I'm going to do the very difficult job of trying to portray how amazing her work has been in this space without her being here. So bear with me. Worth saying at this point that she's very happy to share her details. So if anybody has any questions or wants to talk to her more about it, please let me know and I'll put you in contact with one another. So as I've advised, we met through the fellowship and we regularly speak with each other about the work that we're doing, which has been invaluable really. And through that, I've learned a lot about the project that she has been taking forward, which is really sort of significant and highlights some of the stuff that we're talking about in the project, in the webinar series. So Sunita's currently running a project as part of the fellowship focusing on outcomes of patients who are admitted to hospital with English not listed as their first spoken language. So these are patients who have experienced a stroke and they're currently inpatients within the hospital. So what she's done is sort of looked at the outcomes in terms of their care. And what struck me the most, and as the slide sort of highlights, is sort of, you know, it shows exactly sort of the disparities that we're talking about within the series and the impacts that this has had on patient outcomes. But not just that, it's also the staff that it's impacted who's been involved within their care. So there's been significant findings from her project so far, and what she's found up to this point, and it's worth noting that we're only halfway through the project, but 62% of clinicians who are treating these patients lack the confidence in treating them because of the language barrier, which is an absolute huge amount or a huge percentage. And then following that, it's 92.8% of clinicians involved in the project reported that they don't feel that they're providing the same service to the patient with a language barrier in comparison to those who speak English. So that is absolutely profound. So not only does it have a huge impact on the patients that we're serving, but the staff who are treating these patients also feel like they're not able to do their job properly. So this sort of response mirrors the patient's response. And sort of what they've highlighted in the feedback is that they don't feel that they're as involved in their rehab process, and that's had a significant impact sort of on their outcomes. So this is health equity, and this is sort of the patient outcomes that we're looking at. And this is absolutely huge and really highlights the sort of inequalities for this cohort of patients. What Sunita's actually trying to do is hope that the outcome of this will be the implementation of a standard operating process, and that'll support the staff and the patients who are involved in these pathways. So what she's trying to do is use that data to really improve that service, to improve the outcomes for these patients. I absolutely have not done that to injustice at all. So please let me know if you're happy to have a chat with Sunita. Like I said, she's very happy to share her contact details because I think it's, you know, it's really vital and will feed into a lot of work that you guys are doing as well. So today then with us, we are incredibly lucky to be joined by Natasha and Amy from 100% Digital Leeds. We have Linos with us. I don't think Linos is on the call at the moment. She's currently in clinical commitment, so hopefully she'll be joining us just a little bit later. We have the wonderful Graham who's with us today, and then I'll be finishing off these sessions as well. So without further ado, I'll hand over to 100% Digital Leeds. The floor is yours.
Thank you. Good morning, everyone. So my name's Amy Hearn and I am Digital Inclusion Manager at 100% Digital Leeds. I'm joined today by my colleague Natasha Hill, one of our Digital Inclusion Officers. 100% Digital Leeds is a permanent team in the Integrated Digital Service at Leeds City Council, also covering the West Yorkshire ICB. Our team leads digital inclusion for the city, and our ambition is for everyone in Leeds to have equal opportunity to use digital tools and services in the right way for them. The people most likely to be digitally excluded are also those most likely to experience health inequalities. For example, 46% of people living in economically deprived areas of Leeds have multiple long-term conditions. If digital inclusion isn't considered digital transformation can exacerbate those existing health inequalities. So Natasha and I are here to share how we support digital inclusion in Leeds and how we've worked with health partners to embed digital inclusion support within their services, ensuring inclusive digital health transformation, and how we can work with other partners. Next slide, please. So Natasha's going to talk a little bit more about how practically we have done some of this in Leeds, but one of our objectives is to build a coordinated and connected digital inclusion ecosystem across Leeds. So what that essentially means is that we work with hundreds of different partners, teams, departments within the city that are working with and in communities more likely to be digitally excluded. We work with those services to understand what digital exclusion looks like for the particular people that they support, and then look at what digital inclusion support would look like if it is tailored to meet the needs of those specific people and communities. And then we work with those organisations to support them to embed the correct digital inclusion support into their existing services. And in that way, we're building essentially a digital inclusion safety net across the city, so that where people are more likely to become digitally excluded, because of course digital inclusion is not an on-off switch, it's something that is fluctuating by all the time and is impacted by external factors. So for example, cost of living increase has massively impacted digital exclusion, as people have been forced to prioritise their income and reduce costs around Wi-Fi, etc. As people become digitally excluded, they're more likely to interact with different services. So by embedding digital inclusion within those services, we have put the support where it's most likely to be needed when people find themselves in that situation. That safety net means that we can work with other organisations that are likely to see people that are digitally excluded and would like to support people to be digitally included, so that people can make best use of tools and services, and so that those organisations can signpost people into that existing support available. And Natasha's going to tell you a little bit more about that. Next slide, please. So we're 100% digital Leeds, so we have responsibility for digital inclusion for the Leeds boundaries, and everything that we're talking about today is all primarily related to Leeds. But I just wanted to let you know, if you're not already aware, that we also have Digital Inclusion West Yorkshire. So Digital Inclusion West Yorkshire is a piece of work led by West Yorkshire Combined Authority, where each of the local authorities in West Yorkshire that isn't Leeds have been funded to employ a digital inclusion officer who is being essentially mentored by 100% Digital Leeds. So everything that you hear about here is hopefully going to be replicated, but working towards each local authority's individual priorities across the next couple of years. So you'll see a lot of support in Leeds that isn't there in the other authorities quite yet, but it is underway. And conversations are able to be had at the moment. Next slide, please. So I'm going to hand over to Natasha for the next few slides.
Perfect. Thank you very much, Amy. So hello, everyone. I'm Natasha. So why is digital inclusion important? So we see digital inclusion as an enabler for whatever people want to be able to do. And everybody in Leeds should have an equal opportunity to use digital tools, technologies and services in the right way for them. And we find that those that are least likely to be online are the ones that would most benefit from it. And it also means that everybody in Leeds should be able to make an informed choice. And if you find that somebody's saying no because of a barrier, that's not an informed choice. So what's it mean? It's having access to the resources they need to be able to develop their digital skills. It's having access to the resources they need to be connected. They want to feel confident in their ability to engage with digital. And the motivation is people should understand the personal relevance of digital tools to their lives and how using digital tools, technologies and services can benefit them. There are more barriers, such as social isolation, but these are the ones that we find that are most common. Next slide, please. So 100% Digital Leeds takes a community-based approach. So by developing a network of organisations offering digital inclusion support, health partners can then signpost into them organisations. So we look at strengthening a place to empower the person, and in practice, it looks like a place where people feel safe. It's from people they know and they trust. It's from people who understand their situations and communities, and people are supported in a way to do things that are important for them. It's person-centred approach, so making sure that people learn at the right pace for them. And it's also being able to have the support to access the right equipment and connectivity. This is all done through interventions to meet the communities and enable partner priorities so that digital inclusion becomes business as usual. And when it's done right, it's not more work, and it gives organisations more capacity in the long run as people can be more independent to do things for themselves. Next slide, please. So how can 100% Digitally support you? So we start off by wanting to learn about your digital inclusion needs, and by having a chat, we learn about your services, the communities and the people that you work with. We want to support and develop digital skills and confidence so people feel empowered to support others. We work with multiple organisations to help form partnerships, such as linking in with community organisations offering digital inclusion support, and businesses with corporate volunteers to support digital inclusion, which will support capacity and address other digital inclusion issues. Once we have all of this information, we can be better placed on what funding and resources, such as gifting through the National Data Bank or devices through the National Device Bank, and we work out what would be most appropriate for you, your organisations and the communities you serve. We can help you to understand what digital inclusion is and how to have these positive conversations. 100% Digital Leeds, we don't have our own strategy. However, we make sure to feed into other Leeds City Council strategies, city and regional strategies, health strategies, as this just isn't a focus for 100% Digital Leeds team, but it should be a focus for everybody. Next slide, please. And I'll be passing back over to Amy. Thank you.
Thank you. So this slide summarises some of the work that we have done with different health partners in Leeds, picking some of the sort of golden threads of what we've done that I can share with some examples. So as we mentioned, we've built this safety net of organisations that are offering digital inclusion support across the city. We understand that often health partners are not well placed to have a lot of capacity and time to spend with individuals, supporting them to improve their digital skills to be able to use digital tools and services. We think that digital inclusion is everybody's role, but that role depends on the situation of that member of staff, how much time they've got, how much capacity they've got, how much of a relationship they have with the individual in front of them that needs that support, whether they're set up to be able to take that person-centred approach. So all of this work that you can see on the slide is thinking about that, thinking about what health clinicians or people in non-clinical roles, what different roles they can play, where they can support digital inclusion themselves, where they can signpost out to others, and how different partnerships can work across sectors so that we're all supporting digital inclusion for the right reasons. So firstly, one of the things that we think is key is embedding digital inclusion into service strategy. So we always talk about digital inclusion as an enabler to achieving whatever outcomes the organisation wants to see. And that's the same for all of our partners across any sectors. We're very rarely working with organisations whose primary aim is supporting digital inclusion. Usually they're wanting to support something that digital inclusion will enable. So that might be improved health outcomes, it might be employability, it might be social inclusion, all sorts of different things. So looking at how we can embed digital into various strategies as an enabler to seeing the outcomes of those different strategies. And then also that we can align digital inclusion support alongside and embedded within rollout plans for different digital tools and services. So we're always trying to look at how digital inclusion can be put within a more understandable context. It's a little bit abstract a lot of the time for people to be able to understand what it is they can do and also why they should be doing it. So to give people sort of the understanding of, you know, the relevance and the impetus to engage there, we found that it's been most successful where digital inclusion has been embedded within rollout plans for particular tools and services, so that people can see literally what the impact of that work would be. And that's something that we can support with. For example, we've worked with various primary care settings where they've wanted to roll out digital tools such as patches or AirMid, where they have, similar to how Natasha described earlier, how we work with different partners, speaking to that practice about what capacity they have, what role they're able to play, what they're not able to do themselves, and then looking across our partnerships and seeing who is available to do some of that stuff that the health partner can't do. So that might be linking a GP practice with a local community organisation, that practice supporting the organisational staff to have the practical skills that they need to be able to support others to use those health tools, and also an understanding of the benefit of people using those tools. Is it going to mean that they're not going to be, you know, queuing on the telephone to try and get an appointment for ages? Is it going to be that they're not having to travel across the city? Whatever the benefit might be, so that organisation, the community organisation, can have that person-centred conversation, can essentially open people's eyes to the possibilities of how engaging with digital tools might make their life easier, even though they might be a bit scared, they might be lacking in confidence. And then that community organisation can practically support people to develop the skills and confidence they need to be able to use that tool. That can also involve bringing in other capacity, as Natasha mentioned, around linking organisations to Good Things Foundation to be able to access different resource, such as SIM cards for gifting, such as equipment for gifting, where connectivity is an issue for people. It could be about linking with corporate volunteers as well. So we've had volunteers from companies going into GP practices to support patient uptake of patches around skills as well. Supporting staff to work in a digitally inclusive way. So we can deliver digital inclusion awareness training for staff and volunteers. That is a really good way for us to be able to understand what you're able to support and what your needs are in terms of what you're not able to support, so that we can help make those connections and develop that additional, or bring in additional resource, as well as helping your staff and volunteers have an understanding of what digital exclusion looks like, where there might be more prevalence within your patient cohorts or people or service users, and the different kind of ways to be able to support it. Helps us understand more about your patients or people as well, so that we can think more about the different partnerships that we might be able to facilitate for you or with you. Also, teams exploring opportunities for embedding digital inclusion support or more digital inclusion support within their day-to-day practice. So where those teams who recognise that they are working with people who are more likely to be digitally excluded, and that digital exclusion is having more of an impact, where their services, where they might have a bit more capacity to work in a person-centred way and to offer that more in-depth, long-lasting support, then we can work with those teams to look at how they might be able to do more for themselves or with their people to support digital inclusion. I'm going to talk about an example from Leeds Community Healthcare in a moment, where I'll share practically how some of that has worked. And then supporting staff with needs assessments or screening questions as well, to further understand the digital inclusion needs of patients. So we can look at prevalence of digital exclusion, and we can look at where the groups of people that we think, based on sort of model data, are more likely to be digitally excluded, and how they're more likely to be digitally excluded. But that's all based on sort of stereotypes and assumption. The best way to understand what a person in front of you needs in terms of digital inclusion is to ask them. And we've worked with various different teams to include digital inclusion based questions within their sort of screenings, so that they can understand that need and then support it or signpost out. And then finally, supporting effective signposting. So within that digital inclusion awareness training, we can support your staff to understand how they can have motivational conversations with digitally excluded people. So that helping people to understand why they might want to go out of their comfort zone often to engage with digital tools and services, which is often something that they've not done before, they don't really understand, and is very sort of stressful and scary. Being able to explain help people think through what the potential benefit might be to them really encourages people to engage with those tools and services. So I'm going to talk a little bit more in a minute about that. And then finally, we have developed a digital inclusion delivery resource drive mostly for community organisations that are supporting that digital skills on the ground. A lot of those organisations have got aims and objectives around supporting access to health, supporting reduction of health inequalities, and they've got the capacity and the equipment and everything to do that. They just need to know a little bit more about what the tools are that you're using and how to use them so they can support others. So that's something that health teams can feed into as well. Next slide, please. So as an absolute minimum, we encourage and would like to see different health partners doing these 3 things. So when I was talking before about how digital inclusion we feel is everybody's role, but that role depends on what they're able to do. Where it's a health partner that is working directly or speaking directly to patients, people in one way or another, so that could be clinical or non-clinical. Even if people don't have very much time, hopefully they're able to do these 3 things. So firstly, raising awareness. So telling people about the digital tools and services they might benefit from using. There are so many different health tools and services out there around health participation and transactional stuff, but around self-management tools as well. And we've found in the past that sometimes people don't tell everybody about those different tools because they maybe make an assumption about whether that information is going to be relevant for the person, maybe sort of assuming, oh, this person's older, so they probably don't use digital stuff. And telling them about this or explaining too much might sort of confuse people. If people aren't aware about the different tools that are available, then they're not going to use them. Having positive conversations is one step above that. So not only what the tools are, but what some of the functionality is, why that person might benefit from engaging with that tool, especially if you're able to do that in a person-centered way. So often these tools have got multiple different functionalities. But if somebody is explaining about, for example, how a long-term condition has impacted on their life, and there is one tool that one function of a tool that might help them in that way, then you can use that as a sort of hook to encourage people to engage with that tool. And then finally, signposting to support. So in the safety net support that we created across the city, there were lots of different organisations, some of them supporting communities of geography and some communities of interest. So that support's embedded within organisations that have got the skills, knowledge to a resource to be able to support really specific groups of people within the community. So understanding what support is available and how you can signpost people to the correct support for them. Next slide, please. So this is a screenshot of our community digital support directory in Leeds, and all of those different dots are different organisations that are offering digital inclusion support that can be signposted into. We only include organisations on here where they are able to take that signposting. If you click next, hopefully a box should pop up on here. Yeah, so if you click on each of those dots, you can see it's really pared down information on here. Just yes, no to some of the questions. Do they offer data gifting? Do they offer equipment on site? Do they learn equipment, etc.? And then the primary audience at the bottom there, who they support. So this is designed as a really quick way for people that are supporting other people or looking to signpost to see what is available and do that initial signposting. Next slide, please. So really quickly, I just wanted to talk about how Leeds Community Healthcare have worked with us to do some of this stuff. So initially we started working with them, supporting implementation of specific digital tools. So some of those include MyCOPD, working with the 0 to 19s team to develop their baby bubble program. So working with, where the specific implementation of tools, basically. So following on from that, they developed a staff digital champions network. So that being a network of key staff within each of the different teams that are a bit more confident in digital, that people sort of within the team already go to for support, so that we could get an understanding of what was going on with that team in a wider sense, what sort of plans they were working on, but also what some of the barriers might be to that the staff supporting digital inclusion. Following on from that, we fed into some digital innovation workforce development conferences where digital innovation and digital inclusion were positioned as being side by side and integral to each other, and also how they were going to support sort of cost savings within the service and improvements to service delivery. After that, we worked with them to embed digital inclusion within their digital transformation strategy to make it really, really clear how digital inclusion was going to support that strategy implementation and how it wouldn't work without it. Then we worked with them to develop the digital inclusion questions to be added into their current screening, so that every new patient or person, we're getting an understanding of what sort of their digital inclusion or exclusion looks like and what support might be needed. We've also co-designed a digital inclusion awareness training video. So a 25-minute video that is put within the context of why digital inclusion is important for LCH, and especially with all of this being woven into the service readiness plan for the new patient information hub, so that everybody watching is aware of why it's important and what their role might be. So every staff as well as aware at LCH is going to see that. And then within that video, there is an offer to any teams within LCH that the message resonates with, that sort of see themselves as being a team that supports people that are more likely to be digitally excluded, or that digital exclusion can have a bigger impact for what they're trying to do, so that we can then work with those teams separately to do another workshop that looks at their team and their service and their patients and how we can work more intensively for their specific issues. So that's it from us. That was a real whistle-stop talk, so we've not had very much time, but we're really keen to speak to anybody who would like to hear more about any of these programmes or any of the other work that we've done to support digital inclusion for health, because there's loads and loads that we could have said today. So our contact details are on the slide there, and also a link to our website where you can find lots of information about the work we're doing and impact case studies as well. Thank you.
Well, that's amazing. Thank you both so very much. And just to sort of reiterate, we are sending out a resource document for all attendees. So all of this will be included. And just to sort of take a message, we don't need you to become experts in this. We simply need you to be aware that this type of work is happening and out there. And we will make those connections. So if you want to find out any more, then we'll absolutely introduce you and make that connection with anybody that is speaking with us today. So without further ado then, we have Linos due with us, and Linos was running late, but I think she has been able to join us. Are you with us, Linos?
Yeah, can you hear me?
We can, yes. So the floor is yours. Let me know when you want me to pass on, Linos. I appreciate you're completely juggling at the moment, so you just let me know what you need.
Well, no, they've just changed my clinic route, so I might get some people coming in wanting to set up behind me, so I do apologise, but that's the reality of working at the coalface. So I'm Linos Jones. I'm an asthma respiratory consultant at Mid Yorkshire, and I'm joined on the call as well with Harriet Smith, who helped me hugely with a project that we did recently, and some colleagues from the University of Huddersfield, Dr. Michelle Bartholomew, Dr. Michael Snowden as well. Next slide, please. We basically got a grant to do some work to break down some barriers really to asthma care. And what was quite unique about this, that we wanted to work with patients to co-design a venture that improved equity of access to not only asthma care, but also information about how to self-manage. It was really collaborative, and every step of the way we co-produced the resources. So I'll tell you a little bit more about that. Next slide, please. We the project came about. Obviously, I'm sitting at Dewsbury outpatients at the moment, and I recognised very early on when I was asked to set up this difficult asthma clinic that there were very much sort of institutionalised systemic racism that were serving as a barrier for me being able to give my patients information in the same way if they didn't speak English or didn't read and write. So we wanted real equity of access to care. There was also a complete lack of information for people that didn't speak English, and I just didn't think that was right. You probably guessed from my name, I'm not English either, so I found that really uncomfortable. So yeah, we worked really hard together to create something impactful. Next slide, please. Asthma, as most of you know, is a very common condition. Most of you in the room will know somebody who has asthma. It's about 5.5 million people in the UK suffer from it. And one of the cornerstones really is self-management. And if you haven't got the ability to access those self-management tools, it makes managing asthma really, really tricky. And we had one patient in our trust, it costed over 2 intensive care admissions, and conservative estimates about £70,000 spent on these 2 hospitals. And forget that, she was a young mom, she just had a baby. It was very, really, really, really awful that she'd got that sick. And when we delved into a case a little bit more, she didn't speak English as a first language, she didn't read and write. She'd picked up 4 inhalers in 2 years, which would have prevented all of that. So we've intervened in a different way, and she's not been back in hospital, and she's really, really well managed. So these things do really make a difference. That's just one example, I've got hundreds. Next slide, please. We also know from data from the Severe Asthma Registry that 80% of patients who are eligible for advanced treatments for asthma called biologics, they don't get to them. And of that 80% that don't get to the right treatment, a disproportionate amount of, they call them non-Caucasian patients don't get to the treatment. And we absolutely recognise that language and cultural barriers are real issues in accessing care. Next slide, please. So we recognise it's a huge problem. When I delved into things locally here at Dewsbury, if you just click on a few just to fill the slide up, it'll come to the right to the end. What I did was I looked at the languages spoken using ONS data, and then I looked at respiratory hotspots of overprescribing short-acting beta agonists as a surrogate marker of poor asthma control. And unsurprisingly, there was a correlation between a lack of English proficiency and overprescribing of short-acting beta agonists. So next slide, please. We clearly needed to do something. What we wanted to do was bring our community in as a partner. And for anything that we did to be of a high standard, we felt that things had to be culturally competent, very authentic, very relevant to the patients, and also extremely accessible. And so, when we set about doing everything we did was very much I'm sorry, I'm just in a presentation at the minute. Yeah, that's fine, thank you. I'm so sorry about this. Next slide, please. The first thing we did was we wanted to hear from the patients and community members themselves. So we, with the University of Huddersfield helping, did some focus groups and interviews looking at what were barriers, and surprisingly, what was there already, it had pictures of people who didn't look like a minority ethnic community. The language was very heavily jargon oriented, and that there was a real, it wasn't acceptable to people, that they felt automatically excluded. Next slide, please. So what we did, if you just keep clicking, sorry, there's a few, was we came across with a suite of multilingual videos, and we did this using readily available AI technology. So the lady in the bottom, we nicknamed her Fatima. She's not real, she's an avatar, and she was chosen by the community members. I wasn't sure about using an avatar, but the people that we interviewed absolutely loved her, and she's quite ethnically ambiguous, so people thought she was from all over, and actually, yeah, having somebody speak to them who looked like them was really, really impactful. And we also co-produced a video about Ramadan and the use of inhalers during Ramadan with our trust imams, which was really fantastic to be able to do that. And we access everything through a QR code. Next slide, please. We produced this poster, and what was lovely about the poster was that it was a PDF. It was downloaded all over, not just the country, but our country, but across the globe. So these posters are up as far away as New Zealand. The initial launch, 65,000 people saw the initial tweet. It went across, it was retweeted by huge sort of both grassroots level organisations, but also national organisations such as the Association of Respiratory Nurse Specialists, British Thoracic Society, went to the inbox of every respiratory clinician in the country. So it really, and we were so humbled by people's enthusiasm for this, and also them spreading things even further. So they got retweeted all over the world. Next slide, please. The other key thing, one of the most enjoyable, wonderful thing I've done in my career really, was to work with community members themselves. I found this again very, very humbling. There is a wisdom within our communities. I think as NHS consultants, we forget that people were sorting themselves out long before the NHS was conceived. And I sort of was tight on the aims I gave our community champions, which I trained, and very, very loose on methods. Because I'm respectful, I'm not part of their community. It's really, really important that that the freedom to do what was right for them. And I'm still hearing 3 years down the line those messages coming verbatim back in my clinic. And I'm training next week the 3rd cohort of community champions, so it's been sustained, which has been absolutely wonderful. Next slide, please. I don't believe after doing this project that we have hard to reach populations. I think we've got hard to reach services, and we need to change that narrative. I was opened, welcome, open arms, welcome sister, have some chai. It was absolutely fantastic, and I loved the experience of going to the community. Next paragraph, please. Like I said, yeah, we need to own this sort of responsibility for making our services much easier to reach. Next slide, please. It was wonderful with the community champions to be able to spread and scale. I felt that I was able to convey some powerful messages using those authentic voices. We were able to share good practice. It increased the level of understanding not only in the community, but also our understanding as asthma clinicians as well, what was needed. And the other thing that's really important to respect is that people have very, very strong perceptions about long-term diseases, and what this kind of work allowed us to do was to empower people and to do a little bit of myth busting, and in a very respectful way. Next slide, please. I was really pleased that it evaluated well, so the community work as well as the videos were very well received. People would say things like, aha, now I get it, and thank you for listening, and very, very, very well received. But that was only because we'd co-produced from right at the beginning, I think, and that was something that was key. Next slide, please. I think that we've all got something that we can do to level inequalities and to improve access to care. And I think those circles of influence, we need to respect that we've got those. Things are beyond our control. We need multi-level interventions. I think we need population health strategies for asthma care. But I also think that we can do things day to day. Things like literally, I check everybody's able to read anything that I give them, and appreciate that 1 in 6 of my patients will be functionally literate in clinic. I check that the language, is appropriate, but I'm also doing other things, such as looking at health economics, and I've just submitted a paper to Thorax that we can get some more actionable data freely available and do things at sort of more policy level. Next slide, please. So just a sort of quick take-home aspirations. I think that equity of access to asthma care is crucial. I don't think there's such thing as hard to reach populations. Please, let's change the narrative. One intervention can't do everything. One size can't fit all, but that doesn't mean we shouldn't do anything. I think we need lots more of this actionable data so that we can truly make things that are impactful and relevant for everybody. I think we as healthcare practitioners need to recognise the importance of cultural competence within ourselves, recognise the importance of health literacy and the language that we use in asthma care, and move forward and continue this notion of co-production. Next slide, please. So if I'm not sure this video will play, it doesn't always play, but it's always nice to leave presentations like this with the voice of the people that we most wanted to serve. Will it play? It doesn't always.
It's playing. Can you hear it?
No, I don't think so. It just doesn't matter. It's just a bunch of ladies saying thank you and how much they've enjoyed working with it, and sort of, yeah. So it was a very positive note to try and finish on, but thank you very much for listening.
Thank you so much, Anas. I'm so grateful, especially given the pressures, and really, really appreciate the juggle that you are under at the minute. So thank you so much. Very, very appreciative, and thank you. Such an important message.
No problem at all. Thank you. If anybody wants to get in touch, I'm easy to get hold of. It's just linos.jones@nhs.net. Thank you.
Brilliant. Thank you again, Linos. And I shall now pass over to my wonderful colleague, Graham, who will be talking to us about the importance of PPIE. Graham, the floor is yours.
Thank you very much, Kim, and welcome and to everybody for a few minutes. I usually take about an hour to give this this chat, and Kimberly's very kindly given me 10 minutes. So if you feel that I'm cutting a few corners and going through a few things quite quickly, you're absolutely dead right. What I'm going to do is to put into the chat a couple of important links to things that I'll be talking about. But so as not to distract you for those precious 10 minutes that I've got, I'll put them in right at the end, just so that if you're asking questions, we can address them then. So crack on, Kim. Next one, please. Cutting to the quick, this is Graham's version of the National Health Service. We look after ourselves, we have additional and changing needs, and we go and see our GP. Sometimes we've got urgent and complex needs, and we go to the hospital. Each yellow oval represents a time when we have conversations, discussions about our care, treatment and treatment options and how we're getting on with things. They're different people, different places, different times. And we as a patient have to put all those pieces together, different versions of the same story, and we have to make sense of it all. What's more, we have 8,700 hours to think about that and to contemplate all those complicated different stories that you've told us over the 3 hours that we actually interacted with you. No wonder it's complicated. And we've just so elegantly heard from Dr. Jones how if your English isn't your first language, just how challenging and very challenging that can be. Next slide, please. So when it comes to thinking about the introduction of new innovations into healthcare, then we've got a complicated picture of how do we support the maximum benefit for everyone and not leave anybody out and not miss those with the greatest needs. So in order to do that, we put together a framework that rather than taking a system or professional approach to the introduction of new treatments and care, we've taken the patient-centered approach, thinking about the patient's journey through the system and all the stages that we go through. We might go through in a linear way, or we might loop back and go back to reviewing treatment and trying again till we find something that suits. But we start off by having an open and honest conversation about how we feel and what's brought us to a consultation. And we end up with an agreed way forward that we can work with and live with. And in order to achieve that, we need to do an awful lot of support for different people in different ways. Particularly, next slide, please, if we think about all the jobs that a patient has to do themselves in the privacy of their own home to be able to take something as straightforward as medicines and to be able to do it properly. This is just a sample list of my jobs. I don't get much support, I don't get much help. If I don't understand, if I can't read, if I can't pick up from what I've been given my tasks properly, things don't get done well. And that is unfair, unreasonable, and leads to huge variations in outcomes of care, again, as we've just been hearing. In order to help introduce innovations more effectively, we carried out a whole series of interviews with patients who had experience of new medicines, new treatments, and new diagnostic tools, and asked them what their key themes were. What was the underlying theme that kept cropping up in those interviews? And we realized that availability of support, communication and understanding of information, and for professionals to understand the impact of the innovation on the patient and the patient's narrative and story were all hugely important in the adoption of innovations equally across our health and care system. Those three themes are very important when it comes to thinking about who can help meet those needs. Next slide, please. So the framework that we'll be sharing through the website describes the roles of various stakeholders. Patients, we're a stakeholder. The supplier or the innovator themselves, they're an important stakeholder. The service provider, including clinicians and all the other health professionals that help deliver health and care services, They are a big stakeholder. And of course, who commissions that service, puts up the money and decides how much of how many can be provided. They're a big stakeholder. And if we think about the themes that people have talked about as being important from a patient's point of view, not the system, not the professional, but the patient's point of view, then we think about who can provide support, who can help with communication, and who can help deal with the impact of that innovation on my health and well-being, and how important and how successful that has been for me. Next slide, please. So when we put all those things together, that is our framework that you'll see on the website. Put together an innovation project team who understands, by gathering insight, what matters most to patients. That insight may have gaps, that insight may make assumptions. Those assumptions must be tested, and tested hard, in order to ensure that what we've got is what really matters to patients, and not what other professionals think matters most to patients. Once we know what matters, we can identify who should take what action to address the things that matter most, be that the commissioner, the supplier, healthcare system and professionals, and indeed, of course, the patient themselves contributes to that. It's only when all those stakeholders collaborate, when all those stakeholders work together, and all those stakeholders know what each other is doing to be able to contribute their bit to the patient's journey. And those contributions occur right the way throughout my journey as a patient through the system. I need support, encouragement, so that I can do all the jobs that I have to do properly and in a timely way to get a good outcome. If you put that into an action plan, then everybody knows what everybody's doing. Everybody can rely on other people to do things, and we can effectively communicate that. That is the way to introduce innovation and to get the best possible patient outcomes that's fair for everyone, reaches everyone, and gives everybody an equal chance of getting a good result. Thank you. Next slide. I'll leave you with this. We're not asking a lot. We're not asking something that you don't know or don't understand. This is about a young lad and his dog, the relationship between the two. They share a common interest. They build trust between them. They show that they care, and they're absolutely authentic. Thank you very much indeed. So there goes the links in the chat for you. Happy to take questions, and please get in touch with either Adele or myself, and we're very happy to follow through with anything, be it a presentation, chat through with your own organisation, your own teams, anything that you want to do around this framework. We'd be very happy across West Yorkshire and beyond to be able to fulfil that. And thanks for the chance to chat with you.
Thank you so much, Graham, and so important. And just to reiterate again that all of this information, guys, will be in that resource document that we're sharing. So don't panic. You can access the links that Graham has sent you as well. So please utilise those. And if you've got any questions or any comments or anything at all, please reach out. All of our doors are open, and we can put you in contact with people that you want to speak with. So, really utilise that. Thank you so much, Graham, and I'm incredibly impressed for you keeping to your time. It's such an important and vast subject to talk about, and 10 minutes is just not long enough at all. So we're going to quickly move on, and I'm going to be talking you through this bit, which is unconscious bias. We've touched on this a lot today already within the session, within sort of the past hour that we've had, and you may not have realised it. So what I want you to do now is, everybody behind the screen who we can't see, I'm going to get you to use your brains a little bit and just interact with us as much as we can in a webinar. So in front of you, you can see 6 people, hopefully. Now, obviously, we can't interact, everybody's mics are off and everything else, so that's absolutely fine. So this is just for you and your thoughts at home. So when I wanted to talk about unconscious bias, I thought, okay, what's the best way we can get this across? Because it's quite, it's not difficult to understand, but it's sometimes difficult to capture properly. So I had a little task for you. Like I said, in front of you, you've got 6 individuals. what I'm going to do is I'm going to flash up some job titles or some job roles, and all I need you to do is, based on what you can see in front of you, just see who you would put that job role to. So first off, we have a consultant. I'm going to give you literally a couple of seconds. It's not meant to be sort of in-depth thinking here necessarily. Just your first look at those 6 individuals. Who would you peg as the consultant? Next one, artist. Who would you peg down as the artist? And the next one is stay-at-home parent. Hopefully we're all there. Next one is CEO. That could be CEO of anything, let your imaginations run wild, but we're going to go with the title CEO. Next one is builder. Who among our 6 would you peg as the builder? And last but not least, the carpenter. Who would you have down as a carpenter? So now you can see all the job roles there. You might want to change your mind. That's fine. Go right ahead. That's not a problem at all. And there we go. So these are the titles that I've pegged to each individual. So what we've just done there is unconscious bias. Without knowing it, any experience that you've held or had up to this point, so all the interactions, all the information, anything you viewed, read, heard, listened to, every single experience within your life has led you to the point of deciding who it was that fit that role that you thought was the best. That there is unconscious bias. It's something that we all hold individually that we're not necessarily aware of. This is not something intentional. It's making you aware that we all have our own mental models that we bring to every situation that we face every single day. And you are making these assumptions hundreds of times a day. So the definition then specifically is that unconscious bias refers to the attitudes or stereotypes that unconsciously influence our understanding, our actions or our decisions. So an example of this is a patient receiving different levels of care based purely on their ethnicity or socioeconomic status. So nothing else other than, you know, what makes them them. Why is this important? Well, it's incredibly important. Unconscious bias contributes to the difference in treatment, as we've just sort of specified there. It contributes to the difference in access to care and health outcomes. So that's the health equity and health inequalities that we're talking about. So at the minute, there's a lot of discussion and talk about this example in particular, and there's so many examples, and we don't have time to go through every single one today. But there's a big thing at the moment about pain management and treatment recommendations based on race or gender. So essentially, if you are a woman, you are likely to be treated differently with the pain that you present with, or you're likely to not be taken as seriously as your white male counterpart. That's even worse or less if you're a black male, and all that is down to sort of the perception of the clinician who's treating you. So now we know this, what can we do? So I've put a few sort of things there to suggest. So today isn't about making you guys an expert in unconscious bias. We 100% have not got the time for that at all, unfortunately, but I need to make you aware that this exists and why it's so important when we're talking about health inequalities. And every one of our speakers have talked about it before me. So it's not just about attending the training. You know, this is not a tick box exercise. You need to engage and reflect and encourage other team members to do the same. So you need to create that psychologically safe environment for you, your team and your colleagues and your patients or service users as well. It's really, really important, and I'm not going to sit here sort of in my ivory tower sort of, saying this. It goes without saying that diversity within teams is incredibly important, not just for the obvious reasons, but having that varied perspectives is incredibly important. As a leader or as part of a team, it's not, it's about having your say, not your way. So a good leader makes informed decisions and listens to all of the team members, and only in doing that can you make the best possible decisions for your teams and for your patients or your service users. Let's have a look. So being sort of open and transparent and having that diversity leads to open dialogue, and that in turn leads to trust. So that's for you and your team and your patient, and it's incredibly important to have that trust if you really truly want to help somebody. You need to reflect, most importantly, reflect to be able to have the open dialogue, you need to have some humility. You know, don't be afraid to ask questions. Don't be afraid to invite questions to be asked. You need to be challenged as an individual, respectfully challenged, of course, but you need to invite that challenge, because the chances are, well, not even the chances are, 100% you will not know the full picture, and you'll only get to know the full picture if you take on information from other people around you, and that needs to be diverse. It's your responsibility to educate yourself. Don't rely on others to teach you this. And then you need to beat this drum continuously. You know, this is an evolving practice. You can't attend a session and learn all you need to know. This is an evolving monster that needs to be, you know, thought about often if you want it to be useful and successful. So I have a short video now that I hope that you can hear. Can anybody put their hand up if you can hear that?
Yeah, we can hear it.
The sound's not working on mine. I don't know if it's not working for
Is it working on anybody else's?
It was working for me, but now it's no longer working.
Okay, brilliant. I'll keep playing it. If you can't hear it, we can share the video with you later. I've got Not Now from Deborah as well, so I think it was working. Well, it might be something for you. For anybody who can't hear it, we can share it with you after. It's only a couple of minutes long. So I just thought that sort of captured it really, really well. And the sort of, it's going to play on again. Let me just get the next, for some reason when I click it just presses that again. So sort of my sort of take home message really is that we can all make a difference. Often it just, you know, requires a bit of kindness, a bit of understanding, and just taking a minute out of your time to, you know, truly understand the people or the person who needs your help. We all have a role to play, and I sort of hammered this home last time, but it is really important for you to be able to feel and know that you can make a difference, and in turn that will lead to others within your teams and areas also making a difference. And that is it. We're only 1 minute over, which is an absolutely amazing achievement. I can't believe it. Thank you all so much for joining us. Thank you to the amazing speakers that we've had today. It wouldn't be what it is without you guys coming and sort of sharing the amazing work that you guys have done. But it definitely would not be what it is without all the attendees that we've had today. So thank you so much. I appreciate sort of the rush and trying to get through everything in time, but I really do appreciate your patience with it. And like I said, we're all here. You know, we don't just disappear into thin air after these webinars. We're all here with our jobs, and you know, we're people that care. So reach out and we can carry on these conversations after these sessions and outside of them, the sessions. Everybody has put up the contact details, but if you need any more, if you need any, then just reach out to us and we can get them for you. Mine are on the screen. And lastly, we do have just a very, very quick sort of feedback. I'm not going to say form, it's not a form. I think there's 3 questions in there. So I know that you get asked to do this a lot, and I'm sorry because I'm now one of them people, but can you please leave feedback? It really does help inform the sessions and really helps us improve and know what you guys want. So if you wouldn't mind doing that, that would be great. And on that note, 32 minutes past, thank you all so much for joining us today. I hope the rest of your week goes incredibly well, and we shall see you next week for part 3. Take care, everybody.